Physiotherapy in Neuro Conditions, 15th chapter. Common approaches in neuro rehabilitation. As a therapist, one comes across various types of neurological disorders with various types of presentations that in turn causes different types of functional limitations. However, if one carefully notices the common problems that contribute maximally to functional limitation and needs a greater physiotherapy role, then it has to be weakness, abnormal tonicity, and improper control. Thus, most of the patient's limitation due to neurological disorders is centered around these abnormalities. Hence, most of the approaches is targeted either to increase the strength or improve the control or normalize the tone. Before knowing what techniques that needs to be used, one should know the principles on the basis of which the treatment technique produce results. The beauty of the various physiotherapy approaches in neurological disorders is its ability to bring about the necessary adaptation required in the central nervous system or even in the peripheral nervous system, which contributes towards the achievements. Of course, our brain has the ability to mold itself at any age depending upon the various stimulus given or the demand put in due to the ability that is called a neuroplasticity, but this natural process can be facilitated to a greater extent by physiotherapy interventions. Plasticity is a general term used to describe the tendency to modify or be flexible so as to get adapted to a changed environment. Thus, neuroplasticity is the ability of the brain and neural structures to adapt themselves after its disruption so as to reorganize themselves, which in turn helps in regaining their function to variable extent. During neural plasticity, there is a continuum from short-term changes in the efficiency of strength of synaptic connections to long-term structural changes in the organization and numbers of connections among neurons. We know that the development process which takes place from our birth leads to formation of neurological circuits which is essential to carry out the learned function. Each and every activity we learn during our growth, eating, dressing, walking, combing, etc., leads to a formation of a neurological organization representing a particular activity which makes these activities automatic so that one doesn't have to necessarily concentrate on it. This neurological organization is termed as engram. Engram is defined as a neurological organization of pre-programmed pattern such that every time an engram for a specific task is activated, the task is carried out automatically. Due to neuronal damage, this engram is disrupted, causing inability to perform previously learned task. However, due to the tendency of neuroplasticity, the brain has ability to once again relearn the lost activity by forming new engram by making use of redundant cells and a neuron, but the extent of this ability may vary depending upon various factors. The recovery seen in stroke is a classical example of the brain's ability to learn the lost activity. During a normal living, one does not use all the available neurons in the central nervous system. This is because some of the cells and neurons in our brain and spinal cord are called as redundant neurons, which have a higher level of excitation and hence they don't get stimulated during the normal developmental process, because of which they don't contribute for the various activities performed by a person. Various physiotherapy interventions reach the threshold level of excitations of the redundant neurons so that they take on the function of the damaged neurons. The extent and the rate at which the prognosis takes place depends upon the various factors like the extent of lesion, age of the patient, motivation of the patient, type and skill of physiotherapy interventions. For the low motor neuron types of disorders, the real challenge to the therapist is to maintain the muscle properties and keep the atrophy to the minimum, because the changes in the muscles is irreversible. Hence, if the muscle fibers reduces in number, then even with restoration of neuronal connection, the muscle will not be able to generate the maximum power which it generates under normal circumstances. Various approaches. It is essential one is quite familiar with the various types of approaches used for neurological disorders, and they are as follows: neurodevelopmental approaches, sensory integration, PNF, motor relearning program, biofeedback, strengthening techniques, Brainstorm techniques, Margaret Rood's technique. Neurodevelopmental approaches. This approach of neurorehabilitation that originated way back in 1940 was developed by Dr. Karl Bobath and his wife Berta Bobath, physiotherapist. This approach evolved as a response to the need for more effective treatment of children with cerebral palsy. This treatment technique was discovered from clinical experiences of these therapists and developed over time to deal with the treatment of patients with abnormal movements. Berta found that handling the patient's body made a difference in the distribution of stiffness and control of movement. This became the inception of neurofacilitation techniques used in the treatment today. Through Berta's clinical experience, her husband began to explain the phenomena of responses and recovery her patients exhibited, and thus the neurodevelopmental therapy approach began to emerge. One of the important contributions from this area of practice was a description of normal and abnormal movement as a basis for analyzing motor control. The theoretical explanation of this approach used the current neurological research of its day. Reflex hierarchy theory was in vogue and became the basis of defining and explaining neurological symptoms. The problems in cerebral palsy were felt to be the result of a release of abnormal postural reflexes and tone, which interfered with the development of higher level reactions and equilibrium responses. Writing and equilibrium reactions became the hallmarks of the highest level of skill attainable using this approach. A hierarchical approach to recovery and development was adopted. Sensory information was also regarded in this theory as playing an important part in the development of motor control. Abnormal experience was felt to provide abnormal feedback and interfered with the development of learning more functional ability. As this technique was getting developed, it was found that there was a need to do a preliminary analysis of movement before implementing the treatment process. Analysis of the patient's movement was based on observation and was compared to normal developmental sequences. Contrasting abnormal movement with normal was described. Abnormal movement patterns were described as primitive reflex responses which has lost its higher influences. These responses were categorized and labeled. Clinical approaches developed using techniques to inhibit reflex responses and facilitate more normal activity, such as those seen in higher level responses and reactions, that is, writing and equilibrium. A process of inhibiting abnormal responses was integrated with facilitation techniques to produce more normal control. Of late, the development of new motor learning and motor control theories, it is shown that nervous system no longer functions as a set of rules but has multiple parallel and distributed influences in the development of postural control. These fields of theoretical basis have begun to rule out the earlier belief that motor systems function as an independent unit but have proved with experiments that it depends upon many systems. Thus, motor learning and expressions needs the contribution from various areas to function effectively. Sensory information continues to be considered a valid influence on the movement. This body of research has modified the explanation of how a patient controls movement and relearns control. NDT theory has broadened some of the approaches used in the treatment of neurological recovery because of new findings. The Neurodevelopmental Treatment Association has adopted current information into their approach as explanation for intervention and recovery. Reflexes are no longer the focus of the fight. Analysis of movement continues as a central part of the evaluation format. The use of handling techniques remains the tool used to inhibit undesirable and inefficient postural control. Facilitation of more functional control of movements remains the goal of this approach. The context of functional tasks and the environmental demands are now more emphasized in therapy than was previously described. To date, there has been no formal standardized testing developed by NDT Association. There are some qualitative movements-based exams that have been developed in recent years and are now emerging in the market. Norm, referenced and standardized tests of gross and fine motor performance continue to provide a guide to the therapist for functional performance. These tests are combined with this approach as a basis for examination with the inclusion of clinical observation of the quality of movement. Sensory integration. It has been proved on more than one occasion that sensory system has facilitatory or inhibitory influences on the motor system. Motor system doesn't function independent but needs input from various sensory systems. Over a period of time, researchers have used various modes of sensory systems like cutaneous sensation, proprioceptors, visual, etc. to get the desired motor response. Sensory integration is the term used to indicate a therapeutic procedure which combines various forms of sensory input to get the desired motor response. Sensory integration uses principles such as the following: vestibular based activities. It is given by means of movable surfaces like vestibular ball or tilt board, which helps to stimulate the patient's writing reactions, equilibrium reaction, and automatic adaptation responses. Thus, this exercises helps in improving the balance, posture control, weight shifts, muscle tone, and co-activation of different groups of muscles. These activities also improves the protective extension activity, thus promoting self-control and security with movements. Tactile based activities. It helps to facilitate body scheme and body image awareness. The various modes of tactile inputs that can be given is deep and light pressure input, use of brushing, application of lotions, pressure garments, and self-controlled tactile experiences. Tactile stimulation helps in improving the discriminatory responses and decreases defensiveness. Proprioceptive. Various activities that stimulate the proprioceptors are weight bearing activities, stretching, high impact activities like climbing and jumping. Proprioceptive stimulation facilitates organization of neuromuscular system, co-activation of muscle groups, integration and regulation of modulatory responses, and body perception, which are necessary component of feedback for motor learning. Coordination activities. It uses activities which incorporates timing of responses, pairing of vision with motor outcomes, and ability to localize or target an area of accuracy, as well as grading of muscular activation patterns. This activity helps to facilitate control of rate, rhythm, and timing of muscular activation. The Various activities which are used are finger tapping, skipping, jumping, hopping, kicking ball, catching ball, hitting a ball, writing are some of the examples. Visual motor, ocular motor skills, localization, tracking, scanning, gaze shift, visual spatial analysis, transitional adjustments, and posture control are obtained with these activities. The activity selected should combine active ocular control with vestibular activities in order to integrate ocular motor skill and eye hand activities. Visual motor skills are essential for feed forward control, for developing anticipatory responses, as well as for developing optical and head writing reactions. Oral motor, it uses activities which incorporates active motor control like blowing bubbles, chewing, biting, various facial expression so that it facilitates range of motion of lips, tongue and jaws. This skill helps in facilitating swallowing, blowing, sucking, chewing and oral imitating in praxis. Auditory, it facilitates the perception of auditory information in a way to improve orienting responses as well as assist the motor system to learn how to use rhythm and timing during movement. Use of sound resources to create an outside rhythm to aid in the perception of timing in the control of movement. Music may regulate emotional modulation through the use of relaxation enticed through the use of sound. Rhythmic sounds helps in relaxing, thus can be used to inhibit tone. Arrhythmic sounds, on the other hand, are alerting and hence can be used to have facilitatory effect on the tone of the muscles. Olfactory, it facilitates the integration of smell with gustatory responses and may create an alerting or calming responses in the patient. Sensory integrative therapy can be best practiced if it is carried out in a separate room where other external disturbances does not exist. Moreover, rehabilitation of autistic child can be best achieved when the therapy is carried out in an isolated quiet room. The area should be large enough to provide opportunity for free movement sequences and allow the child self-exploration skill within his or her safety limits. The arrangement in the room should be consistently changed to prevent adaptation of the child, which may remove the stimulating factors causing boredom. The equipment used in the room should provide sensory input and experiences which will prove to be integral for motor and sensory processing. Certain equipments like swing, hammock, bolster, etc. can be suspended to stimulate the various vestibular and proprioceptive apparatus. The equipment should be able to facilitate the motor planning ability of the child and should produce large muscle responses. The child should be given full freedom for executing motor tasks and activities like crawling, climbing, running, and jumping should be encouraged. Other sensory inputs like tactile, auditory, and visual should be incorporated into the activities of the child to improve attention, arousal, coordination, and posture balance. The common equipments used in sensory integrative therapy consist of weights, swings, foams, bean bags, vibrators, turkey towel, cotton, brush, blankets, stairs, writing instruments, trapeze, bars, platform, climbing toys, tunnels, large blocks, candies, balls, bolster, ramps, clays, etc. Proprioceptive neuromuscular facilitation (PNF). This technique to maneuver the motor response was introduced by Hermann Kabak, which was later on developed by Knott and Voss. It deals with making use of proprioceptor to modify the action of the motor system. The main proprioceptor utilized for this purpose is the muscle spindle. The various principles which are used are stretch to stimulate muscle spindle so as to facilitate contraction in the muscles. Lumbrical grip is used to provide exteroception, stretch, resistance and traction or approximation. The movement should be done in pattern because normal activities mostly occur in functional pattern due to the combined action of various muscles. Overflow of impulses is possible for stronger muscles to weaker muscles or from stronger pattern to weaker pattern. The patient should be made to work against maximal resistance to have a beneficial effect. Any movement combination causing functional pattern in the extremities is always initiated by the rotatory components, followed by the distalmost and then by the proximal part. To stimulate the proprioceptors of the joint, traction is given when the movement is done against gravity, and approximation is given when the movement is done towards gravity. Visual and verbal inputs are necessary, hence the therapist should continuously give proper command and also should instruct the patient to look at the movement. In rehabilitation of neurological conditions, PNF can be used for strengthening and lengthening. The strengthening techniques are repeated contraction and slow reversal. Repeated contraction is further divided into normal timing for emphasis and combination of isometric and isotonic work. Of these, normal timing and timing for emphasis is used for neurological rehabilitation. In normal timing, the therapist selects a pattern which is weak and thus comes in the way of functional independency. Hence, this pattern needs to be strengthened. The selected pattern is repeated over and over again from the starting position to the end position. This technique is very effective when there is uniform or generalized weakness of a single pattern. Timing for emphasis is used when there is patchy weakness of specific muscle or group in a particular pattern. Thus, there is weakness of a single component of the functional pattern that needs to be strengthened. Usually, the joint across which the weak muscle lies is used as pivot, and it is at this joint that the movement is encouraged. The movements at the joint distal and proximal to the pivot joint is restricted so that there is overflow and the impulses to the weaker muscle working at the pivot. For lengthening or relaxation of spastic or shortened muscles, hold relax or contract relax is used. Here the spastic muscle is made to contract isotonically in contract relax technique and isometrically in hold relax technique, so that strong contraction is followed by relaxation that in turn help in reducing spasticity or hypertonicity. For rigidity, one can use rhythmic initiation technique in which the movement progresses from passive to active assisted to active, so that the patient learns to initiate movement which outputting too much effort, so that tone of the muscle is kept in check. For cases of hypotonicity in cerebellar disease, technique of rhythmic stabilization which involves alternatively giving resistance to agonist and antagonist coupled with approximation so that it stimulates co-contraction of both the group of muscle, which helps in improving fixation at the joint. Motor relearning program MRP. This technique of developing motor control was introduced by Carr and Shepard. According to this concept, development of a functional task can be achieved best when the task itself is practiced on the whole in the original environment rather than developing other neurological factors like tone, strength, or coordination in a position or setting that is totally different from the actual task. MRP is very effective in stroke patient and can be started as soon as the general medical condition of the patient stabilizes. In fact, motor rehearing program by itself is sufficient many a times in regaining control over various motor tasks. However, other methods which involves either facilitating activity in the flaccid muscle or deactivating a hyperactive muscles like biofeedback may be used in association with MRP in certain cases. Motor relearning program is practiced in 4 steps, which are: step 1, which involves thorough observation of the patient's performance of a functional task. Every functional task has various components that is necessary towards accomplishment of that task. Thus, when the therapist observes the performance of the patient, he is in a position to list out those components that is missing in the patient's performance and is thus contributing towards the abnormal way of function. Then he needs to analyze the reason for the missing component. Detailed analysis can give sufficient information to the patient regarding associated problems which can be anatomical, biomechanical, physiological, and behavioral factors. Along with the other neurological assessment, this observation and analysis gives direct information about the reason for dysfunction in a specific task. Checking tone, strength, control, and supine may not produce enough information about these neurological parameters in the position and the body alignment in which a task is originally performed. Thus, analysis of the reason for lack of various components in a particular functional task executed by patient is very essential. Step 2 involves practice of the missing component using various visuals, verbal, and manual feedback under the guidance of the therapist. Step 3 involves practice of the whole task using the same feedback as above. Step 4 consists of transfer of training during which the patient should maintain consistency in practice. The patient needs to practice the learned task in the environment of his home and when he is alone. The active participation of the family members and relatives during this period of motor relearning is very important. Lack of practice by the patient when he is alone may curtail the beneficial effect of the therapy. Step 2 and 3 usually overlap. In fact, step 2 only comes into picture when the patient does not have a specific component like activity of certain muscle, in which case activation of this muscle is developed before the patient practices the whole activity. A specific task is practiced as a whole. Only when a specific component of the task is missing should the patient be asked to practice the missing component. In fact, once this missing component is activated, immediately the patient should practice the whole activity. Tips given by the therapist will go a long way in helping the patient to understand the flaw in his performance, which in turn will help in rectification of the movement. Proper explanation and demonstration will help the patient in understanding as to why he is having difficulty in performing a task. Sometimes the therapist may have to use his manual guidance to move a limb into a specific position so that the patient does not have to struggle. For example, if the therapist is teaching the patient reaching upwards in supine position, then she takes the arm into flexed position and is holding it to prevent it from internally rotating so that the patient is reminded to keep her elbow straight. The therapist can also use her manual guidance to provide spatial and temporal constraint. For example, the therapist may hold part of the limb to constrain the action spatially to allow the patient to generate a component on his own. Like, for instance, to make a patient assume standing from sitting, the therapist assists the patient in first part of the movement by keeping his affected knee forward and pushing it posteriorly so that it will help the patient to anchor his foot to the ground and use his quadriceps and other extensors to assume standings. The patient develops some control. The therapist decreases her physical constraint so that the degrees of freedom which the patient has to control now increases. At this point in the training, the manual assistance by the therapist should decrease and verbal guidance is given instead. Progression is very important. The patient should not keep practicing what he already can do. Activities should be progressed by making a specific task more complex by either decrease the guidance or by altering the speed or by adding variety. Exposing the patient to different environmental conditions for a specific skill will help him to improve his performances. Last and the most important key is practice by the patient the new skill throughout the day. Biofeedback. The biofeedback used in rehabilitation of neurological patients is EMG biofeedback. It is done with the help of surface EMG electrodes, which is placed in the muscle or groups that needs to be activated or inhibited. The machine detects the electrical activity of the muscles in the form of integrated potentials, which is displayed on the screen in association with some auditory feedback. Unlike clinical EMG in biofeedback, one displays the integrated response from many motor units of the same muscles. With the introduction of computerized machines, the displayed wave represents the average response of all the motor units from which the surface electrode has recorded. The biofeedback machine can be used to strengthen weak muscles as well as relax a hypertonic muscle. For strengthening process, the patient is instructed to concentrate on increasing the size of the displayed wave, whereas for relaxing a spastic muscle, the patient is instructed to try and reduce the size of the displaced wave. EMG biofeedback can be used very successfully in rehabilitating cases of low motor neuron lesions like neuropathy, peripheral nerve injury, etc., as well as upper motor neuron lesions like stroke. With introduction of cordless electrode, it has become very easy to provide the patient the essential biofeedback during functional retraining of activities like eating, brushing, reaching out, walking, etc. Strengthening techniques. Strengthening muscle is quite important in lower motor neuron as well as upper motor neuron conditions. In the lower motor neuron, one has to strengthen the agonist muscles, whereas in upper motor neuron, one has to strengthen the muscle groups which is antagonist to the spastic muscle. Strengthening is essential to bring about good balance between the agonist and antagonist. Strengthening can be achieved in various ways like weight bearing, resisted exercises, using weight, springs, hydrotherapy, suspension therapy, and by using manual resistance. Vigorous resisted exercises are, however, contraindicated in certain conditions like dystrophy, spinal muscular atrophy, as these exercises can increase the damage to the muscles. One needs to follow the various principles like overload, specificity, progression, duration, frequency, complacency, motivation while designing a strengthening program. Brainstorm technique. The technique developed by Brainstorm produces motion by provoking primitive movement patterns of synergistic movement pattern which are observed in fetal life and after pyramidal lesion. This technique is quite extensively used to develop tone and flaccid stage of hemiplegia and pure pyramidal lesion. The main features consist of reflex responses are used initially and later voluntary control of these reflex patterns is trained. Control of head and trunk is trained with stimulation of tonic neck reflexes like AT-NRL, ST-NR, tonic lumbar and tonic labyrinthine reflexes. This is followed by stimulation of writing reflexes and later balance training. Associated reactions are used as a means of developing activities. Hyperextension of thumb produces relaxation of finger flexors. Margaret Root's technique. This technique, which is used for facilitating and relaxing, is based on the following principles. Afferent or sensory stimuli is used to influence motor responses. The nerve and sensory receptors are classified according to types, location, effect, response, and distribution. Technique of stimulation such as stroking, brushing, ice, heating, pressure, bone pounding, slow and quick stretch, joint traction, and approximation are used to facilitate or inhibit the motor response. Muscles are classified according to their action as light working muscles, hand and finger muscles, or heavy working muscles, trunk muscles, and hence, depending upon their classification, appropriate stimuli for their actions are used. Various reflexes like TNR, TLR, vestibular reflexes, and withdrawal patterns are used in the therapy. Ontogenetic developmental sequence is strictly followed in the application of stimuli, hence the therapy is given in the order of total flexion or withdrawal pattern, rolling, pivot prone, on elbows, crawl, standing upright, and walking. Vital functions. Developmental sequence of respiration, sucking, swallowing, phonation, chewing, and speech is followed. The above given approaches are some of the common approaches which are used by the author to rehabilitate patients with various types of neurological disorders. However, while treating a neurological cases, one cannot have a fixed protocol as no two patients with same conditions exhibit similar manifestation. The treatment needs to be tailor-made for individual patients. The theoretical background should be associated with good, innovative, practical ideas to make the treatment session more interesting as well as more effective for the patient. Thank you for watching. Subscribe for more content.